Well, thank you very much, and I wanted to thank Doug and Jim, and again, Rick McDermott and Steve Hanauer for putting this together. Thank you all for staying. This is the final talk, and I don't know if somebody's trying to send me a message, but as I was coming over today, I realized that at DDW, ACG, and now today, I am the final formal lecturer, so thank you for sticking with me. So after ileo-colonic resection, what do? So despite the increase in immunomodulator and anti-TNF treatment, there has been a reduction in surgery, but still 50 to 65% of Crohn's disease patients require surgery. In the year 2013, we still rely on symptoms, so new onset Crohn's symptoms, to start treatment. What that may mean is there are a cohort of patients that you all see in your practices that come in with symptoms that already have damage that's too far beyond the ability to recover with medications. So surgery is not going away for Crohn's disease. Like many good slides, this is a slide Jean-Fred allowed me to use, and I've modified it some, but I think this makes a point. And if you look on the left-hand side of the slide, a patient undergoes surgery. So they get an ileocecal resection with a primary anastomosis, which means for that split second in the OR, they're essentially cured. But look what happens as you go to the right, and this is without any treatment. 1 week after surgery, in macroscopically normal neoterminal ileum above the anastomosis, if you take a biopsy, there's already early recurrence of Crohn's disease histologically in the majority of patients. Go further to the right at 1 year without treatment, 70 to 90% of patients have endoscopic recurrence. However, guess what? Most of these patients feel great. And if you did a CDAI or a Harvey-Bradshaw score, they would be in remission. Going further to the right, and Jean-Fred and others are now looking at tissue destruction and damage, if you got radiographic findings, you would start to see structural changes such that by 5 years, 2/3 of patients have symptoms, and what that means is that over half of these patients need another surgery. Forget about this surgery for a minute. This is essentially the same model you see when you diagnose a new diagnosis of Crohn's disease. The thing is, the patient's coming in with those clinical symptoms already. And as I mentioned, some of those patients have already tissue destruction, and you do a colonoscopy or CT, you said, there's no way you were just newly diagnosed. This looks like it's been going on for years. Well, the post-op model shows us why. Patients are asymptomatic until they get to a critical point of tissue destruction. Well, Paul Rutgertz has really pioneered the post-operative natural course of disease, and he came up with an endoscopic scoring system. And I should make one very important point. This is not a validated score. However, this currently is the best that we have, and I think provides us a signal and guideline in terms of looking at post-operative Crohn's, but I think this score may change over time. But for now, a remission, as defined by most of the studies, means that 1 year after a surgery, when you do a colonoscopy and you go above the anastomosis in the neoterminal ileum, if there's 0, it's normal. 1 is less than 5 ulcers. However, what we define as recurrence, a score of 2 is not too far away from a 1. So this is why I think the validation needs to occur. So if you have 6 ulcers, that's recurrence. 4 ulcers, it's remission. However, a 2 is more than 5 ulcers. 3 is more what we see with active Crohn's. And a 4, they start to stricture. Well, what he showed is that over 70% of the patients, and again, this is back in 1990, so these are not patients who are being necessarily treated with post-op medications, 70% of the patients 1 year after surgery had a score of 2, 3, or 4, which means there's a high rate of progression to another surgery. The other reason I show this slide is just to show you these scores. So you're all used to seeing these small aphthous ulcers. So currently a score of 1 is less than 5 of these. I think a 3 is pretty obvious. This is what we see even without post-operative Crohn's. This is just active Crohn's. And then finally a 4 is narrowing. That's a stricture. And the problem is once you get to this point and possibly this point, that may be irreversible. So how do we treat post-operative Crohn's and what are the options? Well, up until about 5 years ago, this was our standard treatment approach, or these are the options we have, and these still remain options, but maybe some of these are better than others. So 5-ASA, antibiotics, steroids, and then finally the thiopurine analogs. And then more recently, where do the anti-TNFs fall into place? And then most importantly, how do we follow these patients? Does it mandate a colonoscopy? What about fecal calprotectin, small bowel ultrasound? There may be some other ways that we can look at this. And then finally, are there predictors for all of you when you see a patient postoperatively, predictors that you can use to stratify patients and determine who's at a high risk for recurrence and who's at a low risk for recurrence? So this is a slide, and we put together a systematic review in 2009, and actually this table doesn't change very much in the last 4 years, but this is 200 slides put together in one table. And in essence, what we looked at were placebo, 5-ASA, budesonide, nitroimidazole antibiotics. What we're most familiar with is metronidazole, but this includes ornitazole for any Europeans, and then finally azathioprine 6-MP. Clinical recurrence is probably not a good way to follow post-op Crohn's because many patients either feel well, yet they have endoscopic disease, or feel poorly because you've just put them through surgery and they have bile salt diarrhea. So more likely, it's more important to look at that far right column of endoscopic recurrence. And just to summarize, without going through the details, most of the studies did not show superiority over placebo in terms of endoscopic recurrence for these studies that I show here. The two exceptions were 2 out of 4 of the 6-MP azathioprine studies did show benefit, 2 out of the 4 6-MP azathioprine did not show benefit, so it's a split decision. Look at the nitroimidazole antibiotics, and I think what's striking to me at least is the clinical recurrence, 7 to 8% early, looks very good. If we had a medicine that could alter the microbiome without side effects that you could take forever, that possibly is the best strategy for at least post-op and maybe for IBD in general. The problem is when you stop the nitroimidazole antibiotic, the Crohn's comes back, and half of the patients in nitroimidazole antibiotic studies drop out. I know in Pittsburgh with the Steelers, they like their beer on weekends, and people don't like taking metronidazole long term. So what does this mean from the early studies? This means that half of the patients have recurrence, and what that means is that a majority of these patients will go on to their second, third, fourth surgery despite the medicines that I just showed you. So what about post-op anti-TNF? And I think in the last 5 years there's been a lot of hype surrounding this, yet I would submit and argue that we still need more larger data before we can inform decisions. But we are starting to get some signals in respect to this. This was our study that we published back in 2009, which were patients who underwent that ileo-colonic resection, and within 4 weeks of surgery, they either started intravenous placebo or they started infliximab for 1 year. Not to go through this in too much detail, but this was a randomized double-blind placebo-controlled study. This was a proof of concept study, and I'll say this in a different way. This was a pilot study that was not meant to be the pivotal be-all, end-all study. However, we did a power calculation, and we assumed that in 80% of patients on placebo, not on anti-TNF, they would have an endoscopic recurrence, which was our endpoint, and that's what Paul Rutgert's studies have shown. And we assumed, but we didn't know, that 20% of patients in anti-TNF would have an endoscopic recurrence at a year. Power calculation showed a small number needed, which was 24. And as I mentioned, these patients were randomized to either 3-dose induction, followed by every 8-week infliximab with a colonoscopy at the end of 1 year, or they received placebo. And placebo in this is red. Yellow is infliximab, and this is endoscopic recurrence at 1 year. And you can see a separation of the bars with a p-value that's statistically significant. So what does this mean, though? This is one small study, and should this inform decisions? And I would say no. In my estimation, it should not. But there have been a series of other small, some randomized, some open label, so you could argue that there are methodologically problems with these, However, the numbers look fairly similar. Ours is that line 9% endoscopic recurrence at 1 year. However, the 3 top in blue are infliximab, the 4 on bottom are adalimumab, so we have 2 anti-TNFs, showing roughly the same thing, 0 to 21% endoscopic recurrence, which is superior to either placebo or in some of the studies they use 5-ASA. One thing I find interesting is we assumed in our initial study an endoscopic recurrence rate of 20%, and 2 of the studies did show that. So our power calculation, at least a priori, was correct. But now we get into, do we really need to? Do we have to start patients on medicines after surgery? Can't we wait? Isn't it reasonable to wait? And this is something patients ask all the time. They've gone through misery, surgeon comes in, operates on them, and now they come back to you and they feel great. And maybe they're healing from the surgery, but they say this is a fundamental difference that they've never had before from any medicine. And they're sitting and now saying, do I really need to go on medicine? So why not delay treatment as an option in post-op Crohn's? And I think this is interesting. This gives us some insights into mucosal healing. This gives us insights into medical treatment trials, and Brian Fagan, fortunately, is not sitting in the room because I'm going to commit the ultimate sin of not only cross-comparing studies, but cross-comparing mucosal healing endpoints. But I think this is informative and just a way to challenge your minds at thinking about mucosal healing in a post-operative sense, but then also with the medical treatment trials that we have. So these are 4 studies that looked at waiting for endoscopic recurrence, not putting patients on anti-TNF, so going through surgery, and then 6 months to a year later, if they had endoscopic recurrence, then starting an anti-TNF, and then doing another colonoscopy within a year of starting the anti-TNF for endoscopic recurrence. So again, this is not prevention. This is seeing disease, treating disease, and then rescoping at a later time point. And these are endoscopic remission scores that are listed, but you can see that about 1/3 to 2/3 of the patients were able to heal the mucosa and come back into an endoscopic remission by starting anti-TNF. Now I'm committing the sin of sins in academic medicine, but these are the mucosal healing studies for medical treatment trials. So forget surgery, this are the medical treatment trials. And the best that we have so far as a trial is the SONIC study showing 44% mucosal healing. So now we're entering the Winter Olympics, and if you were to assign bronze, silver, and gold medals, I would say for mucosal healing, the bronze medal goes to our treatment, our medical treatment trials. The silver would go to the patients who go to surgery, don't go on anything, but then get an endoscopic recurrence, and then go on an anti-TNF. They do better than the medical treatment trials. And then finally, the patients who undergo surgery and instantly go on immediate prophylactic therapy, 1 year later have the best endoscopic healing or the mucosal healing rates. This is also, I think, a slide John Fred shared with me and I've adopted somewhat, but we know this already. Look at disease duration across the bottom from 0 to 10 years. Look at remission rates across the y-axis. Step up, top down. So very early treatment of patients, we see high remission rates of about 60%. The pediatrics studies have shown this. Early onset Crohn, go to anti-TNF in the form of infliximab, pretty high rates of endoscopic remission. SONIC, within 2 years, so we're getting maybe a little bit further than immediate diagnosis, but within 2 years starting treatment. What about our old studies? We don't talk about CHARM and ACCENT in some of the older studies, but these are patients who had disease for a long time, then went on anti-TNF, you see a drop-off. And then finally, the postoperative treatment studies where we show prophylaxis immediately after surgery and mucosal healing is the highest. Well, I'm going to present now a slide that I've not shared with a large audience, but we've just submitted this for publication, and we're hoping this will be published soon. We followed our 24 patients from that first study out to 8 years. So we've written the manuscript. It's not in press, but it's been submitted for publications. Most post-op studies stop at 1 year. So what happens now out to 8 years? So this is now our long-term extension, and I'll just show you one slide to walk you through this very briefly to give you an idea. So These are the patients that went through surgery. I already showed you this, and they were randomized to infliximab or placebo. And then you start at time 0 on the left-hand side, and then you get out to 1 year. And we know in the infliximab group, which I've already shown you, we had 1 recurrence. So this is a patient who's probably a primary non-responder, but 10 of the patients were in remission. And I'll stop here and say, yes, the numbers are extremely small, but we'll show some signals. Then, at the end of 1 year, the patients had the option with the physician who was still blinded. Remember, when you go through trials, if you break the blind early, there are a number of biases. So we didn't know at the end of the year what these patients were on. But 3 of the patients who were in remission, and I think this tells you something about human nature, 3 of the patients said, I will continue, not knowing they were on infliximab, but I'll go ahead and use every 8-week infliximab going forward. In the patients who continued infliximab out to 8 years, we have not seen a recurrence and we haven't seen a surgery. Also human nature, though, when somebody's feeling well, what do they want to do? Stop their treatment. So we had 8 patients who were in complete endoscopic remission at the end of the year and said, thank you very much, I've enjoyed the trial, I hope this helps you, but I don't want to continue on IV, whatever IV I'm getting. So they stopped. All 8 of those patients, now out to 8 years, have had a significant endoscopic recurrence, and 5 of those 8 patients have undergone another surgery. Again, this is a high-risk group of fistulizing patients, and I should have said that up front. So what about the placebo patients? These are the patients who you would essentially say, let's wait to treat. So they didn't get any anti-TNF that first year. In that group of patients, those that then went on to start an infliximab, and it's interesting, higher recurrence rate, they see disease. They didn't know they were on placebo, but they wanted to do something. So I think psychologically this tells us something. So they went on every 8-week infliximab, 12 of the 13 patients. In that group, 5 of the patients out to 8 years still had endoscopic activity, and all of those patients went to surgery. Now, you can't read the fine print, but most of those patients at a year had already a score of 4, and some of them had a score of 3. What that means is there's a tipping point beyond which we get that we cannot reverse disease, and that's why we saw surgery in that group. The 2s, the less severe scores, we were able to reverse and are in remission. And then finally, one patient, unfortunately, does not have insurance, and now this patient's on their 4th surgery. So how should we manage post-op Crohn's? I'm going to leave you with 2 practical approaches. I think we need to take into account risk factors when we decide what type of post-operative strategy there is. It's clear to everybody in this room that cigarette smoking is bad for post-op Crohn's. So that represents a higher risk group for those that continue to smoke. I leave this as a question more than, I would say, definitive, but I do wonder if patients have broken through immunomodulators, if that's a higher risk group. You could argue, based on the recent Gastro Journal, that maybe azathioprine 6-MP is ineffective alone, so is that really a high-risk group versus ineffective treatment? We can discuss that. Another clear high risk is penetrating fistulizing disease, and another one that I think all of us accept are multiple surgeries. So this study, hopefully in the next year, will be published. So for the first time in a while, we'll have our long-term extension study, hopefully this POKER study, and the PREVENT study that hopefully will have data by this time next year to present you some more information. But the POKER study essentially took a group of patients and waited for recurrence before becoming aggressive. And you can't read this, don't try to read it, you'll get a headache, but I just put it up here because this is an algorithm that reminds me to talk about it. But the patients essentially went on metronidazole 400 milligrams twice a day for 3 months. Then the low-risk patients, so those that had their first surgery, those that didn't have multiple surgeries, weren't fistulizing patients, weren't smokers, those patients went on no treatment and were scoped at 6 months. On the other side, the high-risk group patients were patients who had multiple surgeries, fistulizing disease, and smokers. Those patients went on thiopurines. If they had been on thiopurine, failed, or were intolerant, they went on adalimumab. That was the anti-TNF in this study. And Michael Kam, who's run this study, has shared some data with me, but it looks like the anti-TNF is more superior, and maybe Jean-Fred has some information, more superior to azathioprine, but there are a group of patients on azathioprine who have maintained remission. So I'll leave you with my approach, and this may be a combination of all the algorithms and approaches out there, but I really stratify my patients into low, moderate, and high risk for recurrence. Who are the low risk for recurrent patients? These are the patients who've come to their first surgery after a long period of time for a stricture. I would not recommend putting these patients on anything. I would recommend doing a colonoscopy at 6 to 12 months. If they're free of disease, leave them alone. If they have disease, put them on treatment. The moderate risk group are more what you see, less than 10 years from diagnosis, coming to their first surgery, and they've really never been on anything aside from 5-ASA and prednisone or corticosteroids. This would be the group. I'd definitely consider metronidazole. If they can tolerate it, I think that's a wonderful medicine in combination with azathioprine. And then finally, the high-risk group is the study that we looked at. These are patients who have penetrating disease, multiple surgeries. This is the PREVENT study for those that are familiar with this. Maybe this is the group we intervene with early anti-TNF. And I should modify this slide because I will tell you that when I start anti-TNF now, even for post-op, I will use a low dose of methotrexate or azathioprine or 6-MP in combination, and that's not on this slide. So thank you very much for your time.